this video lecture is in vivo testing of allergic disorders. In vivo testing in the diagnosis of allergic diseases represents the gold standard of allergy diagnostics as it always observes the body's real response to an allergen under natural conditions. These methods have high diagnostic value since they demonstrate direct interaction between the patient's immune system and the suspected allergen or multiple allergens, which can be fully replicated in laboratory conditions. When properly performed and interpreted, skin tests can accurately identify the causative allergen and help prescribe appropriate therapy. The results of in vivo testing are available within 15 to 20 minutes after the procedure, which is particularly important when rapid diagnosis is needed. In vivo testing include provocative tests, conjunctival test, nasal test, inhalation test, oral test, skin test, and elimination tests. Provocative tests are not performed if the patient has such circumstances. The underlying disease is in a difficult stage. It's possible that complications have occurred. Concomitant diseases undergo an exacerbation stage. Is a major disease in the period of exacerbation. Diseases that are not related to the underlying disease are in development in the acute phase. The patient has an acute period of chronic infectious disease. If the patient at the time of the study, pulmonary cardiac insufficiency second and third degrees, active phase of rheumatism, severe liver disease, kidney dysfunction, acute inflammatory process, active tuberculosis, heart disease during decompensation, bronchial asthma of complex shape hyperthyroidism, third degree hypertonic pregnancy, the patient's sensitivity to the action of the allergen is so high that it poses a risk of severe consequences. Skin tests are the standard of diagnosing allergies and are performed during remission of allergic diseases. Trained medical personnel in specialized allergology cabinets of polyclinics and hospital departments can only perform skin tests. Healthcare professionals should be able to provide first aid for anaphylactic reactions that may occur during allergen testing. For this purpose, the room where the tests are performed must be equipped with the necessary equipment and medications. The allergy skin test is a biologic assay used to identify the presence of specific IgE antibodies on mast cell surface. A positive result is observed when a particular allergen is introduced into the skin, leading to the development of a wheal and flare reaction within 15 to 20 minutes. It's important to note that sensitization is an immunological term and does not necessarily imply that the person is allergic. Allergy, on the other hand, indicates that the individual not only demonstrates sensitization but also experiences symptoms upon exposure to the allergen. Therefore, the allergy skin test helps determine sensitization and confirms the presence of allergy based on the clinical presentation. During an allergy skin test, the antigen is introduced to the dermis where the mast cells are located. If the mast cells have been sensitized and antigen triggers the cross-linking of IgE antibodies bound to these cells. This cross-linking prompts the release of various mediators such as histamine, tryptase, and glycotrienes. These mediators can induce vasodilatation, increase vascular permeability, and cause smooth muscle spasm. The local release of these mediators at the skin site leads to the characteristic wheal and flare reaction observed during an allergy skin test. Depending on the method of introducing the allergen, different methods of skin test are used. Droplet skin test. A drop of the allergen solution is applied to the skin and skin under the drops is not damaged. Skin prick test. pricking the skin with a needle or pin containing a small amount of the allergen. Skin scratch test. A deep dermic scratch is performed with help of the blunt bottom of a lancet. Intradermic test. A tiny quantity of allergen is injected under the dermis with a hypodermic syringe. Patch test. Applying a patch to the skin where the patch contains the allergen. Skin prick test. The skin prick test involves using alcohol-treated skin on the forearm. A negative control test liquid, positive control histamine solution, and allergens are placed on the skin with a distance of at least 2.5 to 3 centimeters between each drop. Damage is inflicted on the epidermis in the area of each drop using sterile scarifiers, with separate scarifiers used for each solution. The prick test causes small pricks, while the scratch test causes superficial scratching of the epidermis without damaging blood vessels. Responses are then evaluated 10 to 20 minutes after the procedure. Normally, the response is assessed 10 to 20 minutes after the skin prick test. However, delayed reactions may occur. Therefore, it's recommended to examine the skin after 6 to 8 hours and the next day too. The diameter of the blister and erythema should be measured and documented in millimeters, and then compared to the positive and negative controls. The largest diameter of the blister in millimeters should be measured, accompanied by an evaluation of the presence of surrounding erythema, F. flare, or pseudopods, P. pseudopod. For instance, a response to an allergen might be denoted as 7 to 7 FP, indicating a 7 to 7 millimeters blister with surrounding erythema F and existence of pseudopods P. A positive test is one in which a blister with erythema forms and is at least 3 mm larger than negative control. The presence of pseudopody is indicative of significant sensitization. Skin scratch test includes superficial abrasions is made with a needle or any other sharp instrument and the extract is applied to the site. Skin scratch tests have lower specificity than prick tests. Scarification tests for allergens are performed when it's not possible to conduct a prick test. Also, these tests are specific as they have a higher likelihood of producing false positive results. The results of skin testing are used to create personalized elimination plans and when combined with patient history to determine the appropriate use of allergen-specific immunotherapy. It is important to interpret the results of prick tests in conjunction with clinical observation of the disease, patient history, and physical examination. Skin tests may produce inconclusive results in some cases. False negatives can occur due to improper storage of allergens, reduced reactivity in young children and elderly patients, neuroendocrine system disorder, of the use of medications that suppress allergic reactions. Meanwhile, false positives can arise from conditions such as urticarial dermographism, where the test with control fluid may yield a positive result. Errors in the skin testing technique or the consumption of medications and foods that trigger histamine release. Intradermal tests are utilized when the sensitivity to an allergen must be increased in specific cases to diagnose an allergic reaction, particularly when skin prick tests yield negative results despite a clearly positive history. This test often detects sensitization to bacterial and fungal allergens as well as certain medications. Intradermal tests are associated with low specificity, a high risk of side effects, and are frequently prone to false positive reactions. Unlike epicutaneous tests, intradermal tests often exhibit delayed local reactions and both immediate and delayed generalized reactions. Intradermal tests are very helpful in evaluating drug sensitization, determining the initial dose of an allergen for specific immunotherapy, and allergen provocation tests. These tests utilize small volumes of allergens administered using a syringe by injection allergen solutions and test liquids intradermally, with injection almost parallel to the skin surface. The results are evaluated after 15 to 20 minutes and the diameter of the blister and erythema are recorded in millimeters. Patch test. Delayed hypersensitivity reactions, such as contact dermatitis to occupational allergens, metals, rubber, plastics, and metal generally, can be diagnosed using application tests. These tests include patch tests, which are performed using liquid allergens, non-toxic chemicals in concentrations that do not irritate the skin of healthy individuals, or with solid materials such as metals, plastics, and rubber. The classical closed application test entails applying the substance being tested on the forearm or the middle third of the back and covering it with a waterproof covering and plaster. The reaction is evaluated after 20 minutes, 24 hours, 48 hours, and 72 hours. Patients are advised to remove the allergen and wash the area with soap and water if itching or burning occurs. Patch tests are evaluated using a 0 to 4 plus scale as follows. 0 indicates no skin changes, 2 plus indicates erythema and edema, 4 plus indicates erythema, edema, vesicles, and ulceration. Factors influencing allergen skin tests are medications. Significant suppression of the skin reactivity is seen following conventional doses of antihistamines. It's important to instruct all patients to avoid all antihistamine preparates for a minimum of 3 days prior to the skin test appointment. It's very important to routinely double check with a patient or patient's family regarding this issue before starting with the test procedure. Age. The skin reactivity generally declines with age, especially after 60 years of age. Reaction to histamine is generally smaller in infants and young children, resulting in smaller skin tests. Provocative tests is a diagnostic method involving the injection of an allergen into a target organ to detect sensitization. Provocative tests are utilized when there is a discrepancy between a patient's medical history and skin test results, serving as a secondary diagnostic level test. It's imperative that only an allergist immunologist conduct the provocation test, and informed consent from the patient must be obtained prior to beginning the test. Provocative tests can only be conducted when allergies are in remission and have the same contraindications as skin tests with allergens. Adequate medical staff and emergency treatments must be readily available in the event of anaphylactic reactions. To ensure accurate results, patients must abstain from smoking and physiotherapy treatments before the exam. Provocative tests encompass distinct categories such as conjunctival, nasal, inhalation, sublingual, and oral tests, depending on the method of allergen introduction into the body. Conjunctival provocation tests using aeroallergens is done to help diagnose allergic conjunctivitis. During the test, a fluid is injected into the conjunctival sac, If there is no reaction, one drop of an allergen solution is injected into the other conjunctival sac, and the allergen concentration is doubled. The tests with different allergen concentrations should be spaced at least 20 to 30 minutes apart. The test with increased allergen concentration should only be carried out if the previous dilutions does not show any reaction. The test is evaluated based on the symptoms that appear, such as eye itching, eye swelling, eye redness, and lacrimation. Tear collection and examining it for inflammatory mediators and marker cells is feasible. Once the test is completed, the conjunctival sac is rinsed using a physiological solution. The nasal provocation test is conducted in situations where there is a contraindication between the history of allergic rhinitis and other diagnostic techniques. In cases of multiply sensitization to different allergens, and when a preeminent allergen is required for allergen-specific immunotherapy. One drop of a test liquid is introduced into one side of the nose. If there is no reaction, an undiluted allergen and then a diluted allergen are sequentially administered on the other side. The time interval between administering higher concentrations of the allergen should be at least 20 to 30 minutes. A higher concentration of the allergen should only be applied if the symptoms of rhinitis, such as itching, rhinorrhea, sneezing, and congestion manifest. The test can be evaluated using anterior rhinoscopy or rhinomanometry, which show an increase in nasal resistance or a decrease in airflow. Re-evaluation of the test after 6 to 8 hours is necessary to rule out delayed reactions. The nasal cavity is flushed using physiological solution at the test's conclusion. The inhalation provocation test is a diagnostic tool for detecting a patient-specific sensitivity to particular allergens, which can result in bronchial obstruction. The procedure commences by inhalation a control fluid, saline, followed by the recording of external respiratory function indices. If there is no deterioration in the patient's condition and external respiratory function remains stable, the allergen test can proceed. The provocation test starts with the lowest possible concentration of the allergen and successive inhalations of solutions with different allergen concentrations are spaced at least 10 minutes apart. If the patient experiences coughing or suffocation after inhalation of the allergen, the test must be halted and the patient given appropriate medication to alleviate the symptoms. A positive result of the test is identified if the inhalation of the allergen leads to a decrease in forced expiratory volume 1 by at least 15 to 20% when compared to the initial level. It's recommended that only one allergen be tested at a time. The double-blind provocation test is considered the gold standard for diagnosing food allergies. In this test, neither the patient nor the doctor is aware of whether the patient receives a food allergen or a placebo. Lyophilic dried food allergens are placed in opaque gelatin capsules, and the procedure nurse administers them to the patient. 2 weeks before the test, patients are prescribed an elimination diet. Eliminating the suspected causal food on the day of the test, patients swallow a gelatin capsule containing the food allergen on an empty stomach in the morning if they are in good general health. Within 24 hours, the patient's condition is assessed for any changes. If no symptoms appear, the allergen dose is gradually increased until the patient receives a total allergen dose of 8 to 10 grams. If the patient experiences any complaints or symptoms, the test is considered positive and is discontinued. The skin, respiratory, and gastrointestinal organs are the most frequently affected symptoms. In such cases, the patient should receive the required medical attention. Patients with a history of severe allergic reactions to any food product are not administered this test. Sublingual test involves the application of allergens to the mucosa of the hyoid region for 5 to 15 minutes. A local inflammatory reaction in the oral mucosa, such as hyperemia, swelling, and itching, or a systemic reaction like coughing, sneezing, or tachycardia, indicates a positive test. During the test and for the first day following the test, the physician closely monitors the patient's condition. Allergen elimination test is employed to establish the role of an allergen in the onset of disease symptoms. It involves evaluating the patient's condition after ending contact with a suspected allergen. The test is frequently administered to detect food and drug allergies, among other types of allergies. The elimination test serves a dual purpose in the diagnosis, prevention, and treatment of allergy symptoms. In the event of diagnosis, elimination of the suspected allergen and its derivatives from contact is necessary for a specific period, typically 7 to 14 days. This enables the observation of a regression in allergy symptoms, consequently confirming the allergen. The diagnosis, however, needs validation by performing a provocation test at the end of the observation period. Thank you for your attention.